Good morning, students. Today we are going to discuss about anterior pituitary hormones. Pituitary gland, where it is located. It is located at the base of the brain or just below the hypothalamus. It is also called as the master gland. It is a master in controlling other glands of the body like thyroid, adrenal gland and the gonads. It consists of two parts, namely anterior pituitary and posterior pituitary. Anterior pituitary gland can also be called as adenohypophysis. The types of endocrine cells that are secreted in anterior pituitary are thyrotropes, corticotropes, somatotropes, gonadotropes, and lactotropes. Hormones secreted by the anterior pituitary are called as tropic hormones. Tropic means nourishment in Greek. Anterior pituitary gland has three regions. Pars distalis, that is the largest and vascular lobe. It is the major secretory part of the gland. Pars intermedia, it is located between the pars distalis and posterior gland. Pars tuberalis, it joins the pituitary stalk arising from the posterior gland. Anterior pituitary hormone is produced by separate group of cells called as the acidophils and the basophils. In the acidophils, the somatotropes and lactotropes are being secreted. In the basophils, the gonadotropes, thyrotropes, and the corticotropes are being secreted. It also produces two melanocyte stimulating hormones and two lipoproteins, but these are probably not important in man, that is, human being. Hormones of the anterior pituitary gland are thyroid stimulating hormone, adrenocorticotropic hormone, growth hormone, luteinizing hormone, follicle stimulating hormone, prolactin, melanocyte stimulating hormone. Thyroid stimulating hormone. It is a glycoprotein. Its important functions are to induce hyperplasia and hypertrophy in thyroid follicles. It increases the blood supply to the gland. It promotes trapping of iodide into thyroid by increasing the sodium level, that is, in the sodium iodide symporter system. It promotes organification of the trapped iodine and its incorporation to T3 and T4 by increasing the peroxidase activity. It enhances the endocytotic uptake of thyroid colloid by the follicular cells and proteolysis of thyroglobulin to release more of T3. These are the regulations of the TSH. It is being regulated by TRH and it is being inhibited by somatostatin and dopamine. What are the diseases that arise because of this? Hypothyroidism, hyperthyroidism. Myxedema, it is an elevated TSH level due to deficient feedback inhibition. Graves' disease, it occurs due to an immunoglobulin of the IgG class which attaches to the thyroid cells and stimulates them in the same way as TSH. Uses, thyrotropin has no therapeutic use. Thyroxine is the drug of choice even when hypothyroidism is due to TSH deficiency. Diagnostic application. It helps in differentiating the myxedema due to pituitary dysfunction from the primary thyroid diseases. Adrenocorticotropic hormone. It is a 39 amino acid single chain peptide. Its function is to promote steroidogenesis. Cholesterol is the precursor for glucocorticoids, mineralocorticoids, and some of the sex hormones. The adrenal glands are also responsible for the body's fight or flight response. Regulation of secretion. It is being regulated by corticotropin releasing hormone CRH. Diseases. Excess of ACTH leads to Cushing's syndrome. Hypocorticism, it is a level in which there is low ACTH production. It may be due to the use of pharmacological doses of glucocorticoids in non-endocrine diseases. Uses. It is used primarily for the diagnosis of disorders of the pituitary adrenal axis. ACTH does not offer any advantage over corticosteroids and is more inconvenient, expensive, as well as less predictable. The third one is the growth hormone. hormone. It is a hormone peptide which contains 191 amino acids. Its function is to promote growth of bones and all other organs. It promotes the retention of nitrogen, calcium, and other tissue constituents. It promotes utilization of fat and sparse carbohydrates. It induces lipolysis in the adipose tissue. Receptors. Growth hormone acts on cell surface JAK-SCAT binding protein kinase receptors. Somatomedlins and insulin-like growth factors promote growth. It retains nitrogen and some of the metabolic actions. Regulation. The hypothalamus produces growth hormone releasing as well as release inhibitory hormones. Both are peptides. Somatostatin is also produced by D cells of islets of Langerhans in the pancreas and by few other tissues. The release of GH occurs at the time of fasting, hypoglycemia, exercise, stress, IV infusion, etc. Inhibition of GH secretion leads to rise in plasma-free fatty acid levels and high doses of glucocorticoids. Diseases. Gigantism, acromegaly are caused due to excess production of growth hormones. Pituitary dwarfism occurs due to hyposecretion of growth hormones in children. HGH produced by the recombinant DNA technique, somatotropin, can also be used in Turner syndrome and in children with renal failure. Children with constitutional short stature, adult GH deficient patients, catabolic states like severe burns, bedridden patients, chronic renal failure, osteoporosis, etc. It is one of the drugs included in dope testing. Adverse effects. It leads low immunogenicity, no allergic reactions, pain at injection site, lipodystrophy, glucose intolerance, hypothyroidism, salt and water retention, hand stiffness, myalgia, headache are the possible adverse effects. Rise in intracranial tension occurs in few cases. TH inhibitors, somatostatin. It is a 14 amino acid peptide. It inhibits the secretion of growth hormone, prolactin, and TSH. It has side effects like cetoria, diarrhea, hypochlorhydria, dyspepsia, etc. Uses. The decreased GI mucosal blood flow used for controlling bleeding esophageal varices and bleeding peptic ulcer. The normal dose that can be given is 250 μg slow IV injection over 3 minutes followed by 3 mg IV infusion over 12 hours. Octreotide, synthetic octapeptide, surrogate of somatostatin. It is 40 times more potent, longer acting, but only weak inhibitor of insulin secretion. The dose is 50 to 100 μg twice daily. For acromegaly, it is 10 to 30 mg. Adverse effects leads to abdominal pain, nausea, steatorrhea, diarrhea, and gallstone. Lanaretide, long-acting analog for somatostatin, pegvisomant. This polyethylene glycol complex mutant GH. It binds to GH receptor but does not trigger signal transduction. It acts as GH antagonist. Prolactin is a fourth hormone. It is a 199 amino acid containing single peptide hormone. Its function is to cause growth and development of breast during pregnancy along with estrogen progesterone. It promotes the proliferation of ductal as well as acina cells in the breast. It induces synthesis of milk proteins and lactose. Prolactin receptor. A specific prolactin receptor is expressed on the surface of target cells, which is structurally and functionally analogous to GH receptor. Placental lactogen and growth hormone also bind to prolactin receptor and exert similar effects, but prolactin does not bind to GH receptor. Regulation of secretion. Prolactin is under predominant inhibitory control of hypothalamus through PRIH, which is dopamine, but acts on pituitary lactotrope B2 receptor. Dopaminergic antagonists decrease the plasma prolactin levels, while dopaminergic antagonists and DA depleter causes hyperprolactinemia. Though TRH prolactin releasing peptide and VIP can stimulate prolactin secretion, no specific prolactin releasing factor has been identified so far. Prolactin levels in blood are low in childhood, increases in girls at puberty, and are higher in adult females than in males. A progressive increase occurs at the time of pregnancy, peaking at term. Diseases: hyperprolactinemia is responsible for galactorrhea, amenorrhea, infertility syndrome in women. Disorders of hypothalamus removing the inhibitory control over the pituitary. Next one is antidopaminergic and DA depleting drugs. These are a frequent cause now. The third factor is prolactin secreting tumors. Fourth one is hypothyroidism with high DRH levels. Prolactin inhibitors are bromocriptine. Let us see the action of bromocriptine. It decreases the prolactin release from pituitary by activating dopaminergic receptors on lactotrope cells. It increases DH release in normal individuals but decreases the same from pituitary hormones. Has produces nausea and vomiting by stimulating dopaminergic receptors, and it leads to hypotension. Pharmacokinetics: only one third of oral dose of bromocriptine is absorbed. Uses: it should be started at low dose. Hyperprolactinemia due to microprolactinemia causes galactorrhea, amenorrhea, and infertility in women. Acromegaly due to small pituitary tumors is in under inoperable cases. Relatively higher doses are required. It is less effective than octreotide. Parkinsonism, diabetes mellitus, hepatic coma. Bromocriptine suppresses the lactation and breast engorgement in case of neonatal death. Side effects are frequent and dose related. Early leads to nausea, vomiting, constipation. Late leads to behavioral alterations and mental confusion. Luteinizing hormone and follicle stimulating hormone. It controls the production of sex hormones and sperm and egg maturation and release. So the anterior pituitary hormones are TSH, ACTH, FS and HLH. The target cells are the thyroid gland, adrenal cortex, ovaries and testes. The action is on the thyroid hormones. Then the regulation is on the adrenal cortex, egg development, sperm production, egg release and corpus luteum release. Thank you for your attention.